everybody. Welcome to our podcast, Down Syndrome 21st Perspectives. I'm one of your co-hosts, Lee Ferlisi, and I'm with my other co-hosts, Monique Johnson and Ann Lewis. And we have two fabulous guests for you today, not one, but two from Texas Children's Hospital. We have Dr. Katy Ostermaier. She's the director of the Down Syndrome Clinic at Texas Children's Hospital. And we have Dinah Godwin. She's a licensed clinical social worker at Texas Children's with years of experience working with families of children with Down syndrome. So welcome to you both to the podcast.
Yes, thank you so much for the invitation. We're so happy to be here.
We're very excited to have you. So we wanted to start off with what's the latest in the research that you're seeing for kids with Down syndrome and their families?
There's been a lot of research through the years looking at whether there is any medications or pharmaceutical agents that can improve development or cognition. As of right now, there's probably a few of those studies that are still ongoing, but some of them in the past have been closed due to disappointing results. As of right now, there's not anything that's groundbreaking in that realm that I'm aware of. There are ongoing studies, and I'm still waiting to hear about results for some of those. For me, one of the areas that's rather exciting for research related to Down syndrome is in the treatment of obstructive sleep apnea and Down syndrome. Somewhere around 50 to 75% of people with Down syndrome will eventually be diagnosed with obstructive sleep apnea and require treatment. But the treatment for this is very difficult. It usually is CPAP, continuous positive airway pressure, having to use a mask or a machine at night in order to open up the airway, which is very difficult for really anybody to accommodate to, let alone children. So one of the newer ways of treating that I think is kind of exciting, and one of the things that's being done here at Texas Children's is what's called a hypoglossal nerve stimulator. It's an implantable device that puts a little lead into the back of the tongue area that allows a little better tone. You turn it on when you're about to go to sleep at night. It improves the tone of the tongue, pushes that forward and opens up the airway, which I think is a really great alternative to a lifetime of using a CPAP machine. So our otolaryngologists here at Texas Children's are doing research with sort of our older patients at Texas with Down syndrome, are teens and young adults. So it's at the exciting new things in the field.
Is it expensive? Is it accessible?
It is an implantable device. Very good question. I don't know exactly what the device costs. I mean, it is a surgical procedure, so I'm thinking this is probably something that's going to cost a little bit more than maybe a CPAP machine would cover. This is something that insurance covers for adults with sleep apnea. FDA has already cleared this device for use in individuals in the teen years. But it's about showing its effectiveness in Down syndrome and trying to get commercial insurance to cover it.
I know someone who actually recently had that surgery. He's a teenage, he is a young adult. And I was speaking with his mom a few weeks ago, and she was telling me this. So my son Marley's 19. Right. And he had the adenoid surgery and the tonsils, all of that when he was young. Right. And he had a sleep study some time ago, like maybe 5 years ago, and they didn't feel like it was necessary to do anything, extreme. However, now that he's growing, right, and growing even more, they've found that he is having some issues, right, with sleep. But anyway, this friend of ours had it, not even a year ago. That's great. She said that she's really been pleased with it, but of course, her son isn't able to really articulate what it means for him. But just wanted to throw that out there and share that with you guys.
Dr. Ostermaier, what are some of the signs and symptoms that a child would be displaying that would make a parent think that they needed to take them in to see if they needed a sleep study or were having any effects of not sleeping correctly?
That's a great question. Something that I get asked all the time in clinic. The quick answer is the American Academy of Pediatrics recommends that all children with Down syndrome starting at the age of 3 to 4 should have their first sleep study. And the reason for that is because we know that 50 to 70% or 75% of people with Down syndrome have sleep apnea, and that's a high enough percentage that they need to be screened for it. But some of the signs and symptoms that you could look for that would indicate that maybe this person has sleep apnea would be maybe daytime tiredness, but often in children, it can be the opposite. They get a little regulated and can actually be look more like they have inattention or behavioral concerns. And really the child's very, very tired. And that's
like tired but wired. Yeah.
Yeah, so that's where those behavioral concerns are stemming from. Other things that we see very commonly is odd sleep positions. So sometimes kids will sleep in a sitting up position, or they'll sleep cross-legged, but then bent at the waist with their face in their lap. It's amazing that they can sleep that way. But those are positions that I think naturally will open up this airway, allowing gravity to help open up the airway. Restlessness at night is another symptom. So kids that are just kind of moving a lot or tearing the bed apart at night might be having a difficult time finding either a position of comfort, or they're just constantly waking up because of the sleep apnea.
But if you don't notice any of those, you still think someone should go get a sleep study?
Yes, there's actually research on that, because parents often don't know because they're sleeping too. So they may not always know when their child isn't sleeping well at night because the house is sleeping. Obviously, snoring is the most common symptom, and I didn't mention that. But aside from snoring, there can be other things that people just may not know are happening at night when the child's in their own room.
And this has to be done all night long in like a strange hospital room and all of that.
The best way to diagnose sleep apnea is with what's called a polysomnogram or a sleep study. And that is an overnight study. Oftentimes, it's not the best night of sleep that a child has, but if you get at least 4 hours of sleep that's consecutive, then the sleep study can be read. They do have like their respiration rate and their oxygen saturation being monitored. They put a few leads to look at brain waves. So there are some wires that are attached to the child in order to monitor just sort of basic functioning during sleep.
I know that I mentioned before we started this that I wanted to talk about growth hormone, and I kind of feel like this might be a good leeway because obviously you need sleep to grow. But I was wondering if you could just give everybody your opinion on the actual growth hormone, because with our son, when he first was born 6 weeks early, but he was on the regular growth person's chart at like 1%. Since then, he's dropped off of that, and he was always like 50th percent in the Down syndrome chart. And we've always had these bone scan, like the bone age done of his hand, and he is two standard deviations below, but his curve was always on his curve, trending in his way. And so they just thought this is just him and you don't need to worry about it. But this past year, this last checkup that we went to at the endocrinologist, she noticed that he just kind of plateaued. It was enough to make her say that in the next 4 months, when we get back after summer, to re-measure him to see if maybe it was a fluke, whatever. But he is small. I mean, he's 6.5. He wears like a size 4T shorts. Like, he's a little guy. We don't notice any problems with his breathing or anything that you mentioned, like no behavior type stuff. And he's learning, he's reading, like he's doing well. My pediatrician once said, those growth hormones, they work, but they grow things, meaning, you could grow a cancer tumor or something. So that's obviously something that you don't want to do. What do you tell your clients?
I guess my answer could be to answer your question individually for your son, and then kind of talk about Down syndrome broadly when we think about growth. So for your son individually, a person with Down syndrome can have growth hormone deficiency. I mean, it's not everything is related to Down syndrome, and you can have other things too. So it sounds like you're seeing an endocrinologist that's going to work him up and make sure that this isn't just something that should be hand waved at. This is just typical for Down syndrome. Maybe your son requires further treatment for that.
Sure.
But in general, we expect people with Down syndrome to be smaller. That's part of Down syndrome. But there are things that we kind of keep in mind as we're thinking about growth. Thyroid is important to monitor yearly. If you have low thyroid, you're not going to grow well. And so to me, that would be one of the first things I would look at for a child that I was worried about to make sure that was up to date. Nutrition is important. Some of our children struggle. Certainly in that first year, moving from milk or bottle feeding into solid feeding and table foods, and may not have a wide variety of nutrition. They could have nutritional deficiencies, micronutrient deficiencies. So I'm making sure that they're not falling off their growth curve. That's always concerning. A child, even if they're small, should kind of pick a curve and follow that curve. If that's what you see on a growth chart, then I'm usually reassured that this is sort of where they're supposed to be genetically. But if you see children crossing percentiles, that's when a further evaluation would be warranted. In general, though, for Down syndrome, just for small stature, which is part of Down syndrome, at least the endocrinologists at Texas Children's tend to be very conservative. Other physicians around the country I've seen may be a little more relaxed about this, but at least here in our academic setting, they do worry about malignancies and leukemias and Down syndrome and try not to use growth hormone sort of just for what maybe a physician would consider a cosmetic reason.
Interesting that you talked about like nutrition, and maybe you can go into that more. I used to do this Down syndrome intended multivitamin, and I just kind of got like, I can get down that road of all the different alternative things you can do. And there's all these companies that are for Down syndrome, and it gets overwhelming. And then I kind of reach out to a lot of people, and I realized like not everyone's doing that, and their kid is succeeding and their kid is growing and they're smart and they're not doing all these vitamins. And so I kind of stopped.
I kind of approach vitamins individually. I'm with you. I don't think that marketing broad vitamin mixtures to the general Down syndrome population is necessarily warranted. And a lot of those companies are sort of suggesting that their multivitamin concoctions will improve development or improve cognition, which there is some data and a little bit of research out there that is well done that really kind of refutes that, doesn't really show that to be the case. I feel like extra vitamins then are just excreted and you're just kind of paying for,
expensive urine. Yeah,
exactly. But if you think about patients individually, if I have a child that's particularly picky and I know that they're not eating a lot of fruits and vegetables, for example, they may not be getting adequate levels of vitamin C or vitamin D. Maybe they're not getting proper amounts of iron. And with dairy, milk isn't as much of an important nutritional component to their diet after around a year of age, but usually the kids will be eating some cheese or some yogurt or other sources of calcium. You do want to see sort of a well-rounded diet. And if not, then I might recommend just a regular multivitamin. I usually don't go to those expensive ones that are for Down syndrome specifically. Yeah. I think just a regular multivitamin for children will work.
Okay, thank you.
I was just going to ask, since we're on the topic of kind of like vitamins and that whole thing, Dr. Ostermaier, could you, for our audience, could you talk a little bit more about thyroid? Because Marley was diagnosed with that at 4.
Yeah.
His pediatrician waited because she said, around that 3 to 4 year range is when typically they like to put them on the medication. So he's now 19 and he's been taking it, and it has, he's growing and doing what he needs to do, on the Down syndrome growth chart. But just share a little bit more about that and why that's the prevalence of that among Down syndrome.
To get started, around 20 to 30% of people with Down syndrome are going to need thyroid medication at some point in their lifetime. It's the reason why the American Academy of Pediatrics recommends that we screen for thyroid regularly, which is different than you would do for regular well child visits for typical peers. And why do we screen? Like, what are the symptoms of low thyroid? Why don't we just look for symptoms before we draw blood? Well, the symptoms of low thyroid is short stature, being a little bit smaller, dry skin, thinner hair, constipation, and these are all things that are just kind of part of Down syndrome in general. So it's very difficult to differentiate whether this is just something that we see in Down syndrome or if this is related to low thyroid. And because it's so difficult to sort that out clinically, we recommend just the blood test for thyroid.
How do we know when we want to medicate a kid with thyroid? Like, how do you know what number to pick to... Because sometimes I'm thinking, oh, what if he was on thyroid medicine? Maybe he would grow, but then the tests are not revealing necessarily that he needs to be on it.
Those are all very good questions. So extremely common to see a very mild elevation in the thyroid stimulating hormone, or TSH. Actual hormone level is often normal. So what that means, and this is kind of typical for Down syndrome, I was about to kind of explain what is it about Down syndrome that makes thyroid function a little peculiar, different. It means that the thyroid gland needs a little more pressure to produce hormone. So the way this works is TSH actually comes from the brain. The thyroid stimulating hormone comes from your pituitary gland and tells the thyroid gland to produce hormone. In Down syndrome, there's been a little bit of research that indicates the gland needs just a little bit more pressure from TSH in order to produce actual hormone. It's usually just slightly elevated, and we call that compensated or subclinical hypothyroidism. There's been research looking at whether in Down syndrome, compensated or subclinical hypothyroidism should just be treated. We know that all of these things are associated with Down syndrome, growth and dry skin and all the things that we were just talking about, and also the cognitive effects of lower thyroid. There was actually a study done probably over a decade now that looked at that specifically. What happens if we took a group of patients with Down syndrome and we just treated them with thyroid hormone and see how they do cognitively? And what about the other group of patients that we just follow clinically, as we would regularly? And there was actually no difference in cognitive function between those two groups of patients. And so it was determined that treating subclinical hypothyroidism is not recommended. But that also has been done in typical children and in adults. And so really just in medicine in general, that condition does not require treatment. So to answer your question, it's actually pretty simple. You just have to draw the blood. I mean, when it comes to thyroid function, your endocrinologist is going to look for a certain level at that TSH or a low hormone level, and that's when you treat. So it's actually not as tricky as it might seem. It really is just about drawing the lab work and looking.
So the people that say, okay, they have a range and it could go up to like 4 or sometimes 8. Like there's just different ranges that you find. Yeah. But some people say, that's in range, but it's not optimal. So do you believe that under 2 is really what's optimal and all the other stuff is something you should treat?
I would say that when there's a normal range for laboratory studies, it's a normal range because human beings all are wired and function a little bit differently. And laboratory studies have done pretty extensive research around those ranges of normal for human beings. So I usually will tell parents, if it's within that range, it's normal. It's just normal.
Okay.
And you wouldn't want to treat somebody who doesn't require thyroid medication because that can put them into what we would call a hypermetabolic state. It can put extra strain on the heart. We know that congenital heart conditions are very common in Down syndrome. There's lots of reasons why you wouldn't want to overtreat with thyroid medication. It's not good for the body.
Is there a way to improve a pituitary gland if it's not working properly to allow the person to grow?
To improve the pituitary gland, probably not. Probably like the only thing I could tell you about that is just proper nutrition and exercise and sleep and all the things that we do now to keep ourselves healthy would be probably the only thing you could really do there.
Is there any danger to someone not having the appropriate amount of growth hormone in their body?
I think if you actually have an endocrinological condition that indicates you are not making proper growth hormone, there probably are some downstream effects. Aside from just growth, growth hormone can do other things for the body too, and not just growth. And so I would say that is kind of moving into a medical condition that does warrant treatment.
Okay.
Hey, and I want to also make sure we get Dinah in too, Dinah Godwin, who's a social worker. And I know we definitely want to hear from you too. And, I'd love to hear about some of the things that you hear from families.
And so they may come to me and say, what can I do at home to help my child? We're getting speech therapy, we're getting occupational therapy. I'm not sure if he's making, he's not quite making the progress I'd like to see. What can we do? And so one of the things that we always recommend is making sure that you are talking to your therapist about what you can do at home in terms of a home program, because increasing the amount of therapy can possibly be helpful, but what's really helpful is having everyday activities that are sometimes recommended by therapists, but sometimes things that we do naturally with our children, reading them, talking to them a lot, hearing language, understanding that books have words and words have pictures and it all goes together. That can help with some of those pre-academic skills. Another thing that we think is incredibly important is fostering independence from as early an age as possible. Every child, whether they have Down syndrome or not, is able to do something to help contribute to the family. Even a 2-year-old or an 18-month-old who's developmentally in that range can actually take laundry out of the dryer and yes. Is it going to sometimes take more time? Yes. But those are important skills to start building, because these are things we want for them in the future. We always talk about beginning with the end in mind. And I think every parent's goal is to have their child be as independent as they're able to be when they're adults. We start those foundational skills really, really early. And I think sometimes it does take longer and it is harder and it makes a mess when we have kids contribute to things in the household, but it makes a big difference for their self-esteem. It makes a big difference. They see themselves as a part of a team, and eventually those skills carry over to the workplace. So thinking about chores that your child can do, thinking about responsibilities to give to them that are age appropriate. We talk one-on-one with families about some of those things. If you are working with therapists and they aren't giving you home programs or aren't giving you advice, that's a little bit of a red flag to me. And to really push them and ask them for more guidance on what to do. That's something we see a lot, is that the therapist takes the child back to the room to work with them, but the parents don't really know what they're working on. And so you don't need to be in the therapy room, but you do need to know what you can do at home.
Thank you so much for that. Because I have a young adult, right, a 19-year-old, it's very interesting what you said about fostering that independence. And what I've found in talking to other parents of young adult, down like Marley's peers, for example, some of the parents will say, oh, I'm not so sure I want to let him do the metro lift, or I'm not so sure. And I'm like, you've got to let him do it. Trust the process, right? And so talk a little bit more about that. Like, how would you coach a parent? What would you say to a parent as a social worker, or someone who's supporting the family with those, independent milestones, if you will?
Absolutely. Yeah, we have those conversations a lot. At that point, maybe they might say they're thinking about, they hope that they'll be able to work and be independent, or go to school, go to college program. And there are adapted college programs for people with disabilities. There are adapted job training programs, but you have to have those foundational skills. But we'll also normalize that it is really anxiety provoking for families to let their children go a little bit. It's hard even when you have a typically developing child. We have to understand their development and know what they really are capable of. An 18-year-old who is more like a 2-year-old probably can't ride metro alone, but an 18-year-old who's like a 12, 14-year-old probably can, with some guidance, maybe going with them on the metro for a while, having Metro Lift as and these are Houston-based resources, but there's something equivalent in every city. Starting from the home setting and then having them generalize some of those independent living skills outside in, sports activities or at school. Daycare program or wherever they happen to go, they can start contributing in those types of settings too, and eventually giving them the chance to be just a little bit more independent. But I think recognizing the anxiety and the concern that parents have first is important. If you keep them under your, wrapped in their blanket at home the whole time, they're not going to get those skills.
Right.
Yeah, advocating for change when things aren't going the way you think they should be going. Can you give us a little bit of advice on that?
Or some of the other questions that as a social worker I get very frequently are, how can I get more services for my child? How to make my child eligible for Medicaid? Because Medicaid, as some of you may know, Medicaid pays for quite a few services that private insurances don't. And there's a lot of misinformation out there for families that everybody who has a child with a disability can qualify for some of those programs. And it really varies by state. Here we're at Texas Children's, and we're in a state that unfortunately is not especially kind to people with disabilities. The services have long waiting lists. There are
correct. I'm on that list.
You're on I get so excited when someone moves off the list.
I'm on the list.
I've been on it since he was born.
Those waits can
But to jump in there, I'm on the list here in Texas, but we lived in Georgia prior. And I can tell you that they have the Katy Beckett deeming waiver. And so even with private insurance, once you've utilized all of your insurance, then the waiver takes over the rest. And I'm thinking, why is it that we don't have that here in this state? Like, what is really going on? So anyway, that's a question that I probably will not get answered, but I'm just not by you, but I'm just saying in general, probably in my child's lifetime and not in my lifetime either. He's on the 30-year waiting list. So we'll see.
These are questions I get a lot. And a lot of times what I have to do is deliver not very good news to families here in Texas. You're right, though. There's a huge disparity among states. Some states have excellent services.
Yes.
Family income is. Some states have much shorter. I will say all states have shorter waits than. And what are the causes of that? There are a lot of them. But I think one of the important things parents need to sort of start thinking about is how those decisions are made. And they're made by people who represent us, and they're made by people who don't necessarily know the lived experience of people who are with disabilities and people who have disabilities themselves. So the more I know that you have long to-do lists of things that you have to do as parents of kids who have Down syndrome, but understanding that and starting to venture out and step into the world of advocacy is really important. If the people who make decisions don't understand the needs, they're not going to make change. And that's truly the primary way we can make change.
Right.
So Down Syndrome Association of Houston, National Down Syndrome Society, they have advocacy bullet points, I guess, on their websites. There are communities of parents with children with disabilities who get together and advocate. People with children with autism actually have advocated for a lot very successfully. It's still not it should be, but it's been very good in terms of getting access to coverage for some of the therapies that are needed. Some of the other communities haven't had as much luck. And so I think connecting to the fact that this is made by people and the people need to understand, be willing to tell your story, be willing to work with your legislature. If they hear it enough, they might do something about it.
Right. And to your point, thank you so much for that. I do think that Ann and Lee and all of us are very much interested in expanding on the, advocacy role. I will say personally that I've written my local representatives many times about the issues. And I also am on all the list for the Down Syndrome Association and the Research Institute in California, the one that's at the university. So I oftentimes will definitely share and, but it's a whole nother job, really, role, right, to what you already do. But it's these kinds of platforms and having on guests like you all to come on that really just makes me feel confident that with multiple conversations, with people getting engaged, change is possible. Right. I may not get to see it all, but change is very possible.
It is. And you may not be experts on advocacy or on policy or how those decisions are made, but you're experts on your child and your lived experience as a parent of a child trying to access services. So I think it's really important we're actually planning to do a workshop on advocacy for parents here. And so we're happy to share that with Lee. And
please do.
Share that with others. But we're not experts either, but we've learned on the job because we see the huge needs that families have.
I saw on Facebook, and it was just because of our podcast, we get a lot of different things popping up in the feed from different moms. And it was this mom the other night, and Monique and Ann, maybe at some point in your life, maybe this happened to you too, who was just so sad, overwhelmed, feeling like she couldn't get a break. And I don't know if you have families coming in feeling that way, and what are sort of the resources that they can reach out to, whether it's here in Houston or somewhere else, because I think there comes a time for any parent raising a kid with a disability where you hit that wall.
There are some resources out there for respite care. That's something that people are often looking for, is just, how do I get a break? I don't know anyone who's willing to help me. care of my kiddo for just a few hours while I do something.
Yeah.
There are faith communities that offer parents' night outs. Organizations, our clinic sometimes offers parents' night out. Different community organizations have some services. But as far as more structured assistance, like on a regular basis, that's one of those things that's covered by some of those long waiting lists that we talked about.
Yeah. Yeah.
Getting access to some of those services rough. So a lot of times it's piecing things together, like the parents' night out, connecting with other parents to take turns. So that parent support is so important in this whole journey, because a lot of people feel so isolated. They're not able to get out and do things the way that they would like to do. Connecting even virtually with other parents can help, and maybe making those connections for trading off childcare for one night every month. We always talk to our families too, even taking a 5-minute break sometimes of just stepping outside and getting some fresh air it gives you a chance to regulate yourself. And then you're also showing your child that that's important to do. Mommy timeouts are important sometimes. We have a lot of programs here for families of children with a variety of diagnoses, not limited to any particular one, but we have support programs here. We have the respite night I mentioned. We usually do that once or twice a year, where families can drop off their children for hours. And we as our doctors and our nurses and our social workers and our students take care of them.
How do you get to do that program?
The best way to find out anything that we have to offer is signing up for our newsletter.
Okay.
I can send that link to Lee.
Yeah.
I don't know if you have
we'll link to it.
but that's the best way. That's where we announce all of our upcoming programs.
Awesome.
But they're open to the community. You don't have to be a patient of ours to participate in any of our workshops or our programs. We have programs for siblings of children with different disabilities, middle school and elementary school siblings. We'd like to develop a one for older kids. We have some programs for young adults, so your son might be interested in coming along to some of our activities. They're able to be somewhat independent. We would welcome him.
Wonderful. That's great. Dr. Ostermaier, we were also talking about earlier on developmentally some things that you've come across that might be helpful for parents to know about.
We expect some level of developmental delay or intellectual disability as part of Down syndrome, but that varies widely. So part of the mission of our clinic is to help families to understand their child individually in terms of where they're functioning and what sort of resources, therapy, or school supports would be beneficial. I think the first year of life, families are more focused on gross motor delay, learning to sit and walk and
crawl
and get around the world. After the children start walking, I think they start recognizing a little bit more that the language delays. And those are sort of early markers of some level of intellectual disability, whether that be very mild or more on the severe or profound side. We're big proponents of early therapy, early childhood intervention, or therapy through private agencies. Speech therapy, I think, is something that can be incredibly useful throughout the course of a child's life. Some children are very talkative, but sometimes there's articulation errors in there. Still require ongoing speech therapy, even when they're talking a lot, to bridge some of those articulation errors. Some children who may not have a lot of words do really well with communication devices or sign language as a bridge or picture exchange systems. So we're always trying to figure out who this child is, where their strengths and challenges are, and how we can best guide the families to help them reach their full potential.
What about when kids repeat themselves? I know Anne and Monique have talked a lot about that a lot of times their kids will repeat and repeat and repeat.
The repetitive speech,
And sometimes our children actually fall onto the autism spectrum. And
I was going to say that.
Yes.
Which is what I think.
Somewhere around 20 to 30%. They are now realizing people with Down syndrome actually meet criteria for autism. And you can hear some repetitive speech that's just sort of typical.
Even though Marley, my son, has never been diagnosed as being on the spectrum anywhere, but I believe that he has some of that, right? Again, he's 19, so the research and everything has been evolving. If we have a few more minutes, I'd like for you to touch on regression a little bit.
Okay. Yes.
Please, if you would.
Something that would be something that you might see in some of your son's peers, or they're at risk as they're reaching those teen years and young adults. One of the things that we saw probably 10 years ago, maybe it's been a little bit more than that, when I'd be at Down syndrome conferences, people would just talk about a teenager that was doing really, really well, and then all of a sudden seemed to lose really crucial skills, either in self-help or language. It seems to happen very suddenly. And because we had these Down syndrome clinics, we were able to kind of characterize that a little bit better. Now have some resources to clinically understand the symptoms related to Down syndrome regression. It usually is something that's very sudden, loss in ability to take care of themselves, dress, toilet sometimes, even eating. Sometimes children will all of a sudden just sort of refuse or seem to have lost the skill to use utensils. Sleep tends to be very disordered. There's two schools of thought around Down syndrome regression. Some people think this might be an autoimmune phenomenon going on in the brain and requires treatment that is going to sort of quiet down that hyper autoimmune response or inflammation in the brain. Some people feel like this might be more psychiatric in nature. Some people, when they get very, very depressed, they can sort of lose skills or become what we would call catatonic and just sort of not want to move or do anything. And then I'm starting to feel like probably both of those things are true. They're just presenting the same way, but those are two different populations of patients. Some seem to really respond to autoimmune therapy, and others respond really nicely to psychiatric medications. So we have a lot more to learn about this. When I'm teaching residents at Texas Children's, I tell them to don't wait, don't sit and kind of just observe. Jump on this immediately. I've had patients respond so well to a little bit of Prozac, but the earlier you catch them, the better they tend to do. We had a lot of these during the pandemic. And really good results with medication for depression right away, and they would kind of pop back up. So if they don't, then you'll ask your neurologist to help you out and continue an evaluation for an autoimmune condition.
Specifically Prozac, or now there's like a huge amount of these SSRIs that are out there. Does it have to be that one for a particular reason, or could it be any of them?
There are lots of different medication choices that physicians can consider. I personally like fluoxetine or Prozac. It probably has the best safety profile in children. It has a long acting half-life, so it stays in the system at a nice steady rate. If children skip doses, there's not as much risk for side effects or withdrawal. But some people don't respond to it. And so there's lots of other medication choices out there to individualize treatment.
Does your clinic see people that are out of our state, or is it just for our state?
We see people from outside of the state, people coming even internationally. The only complication is that Medicaid is often difficult to process over state lines because that's a state-funded program. But yes, we are a referral source for a wide catchment area.
Especially insurance is more likely to cover if there's not a specialized Down syndrome clinic, somewhere nearer to the family.
Right. Thank you so much for joining us today. It was an amazing conversation, and we so appreciate this hour. We learned so much.
Thank you.
To all of our listeners and viewers, thanks for joining us. Like and subscribe, because we're going to just keep doing this for you. And we appreciate you joining us with Down Syndrome 21st Perspectives.
Thank you. Thank you.
Thank you. Thank you.
Thanks.